Welcome to SickKids Connected Care webinar on Essentials of Oxygen Therapy and Heated High Flow in Pediatrics. Please take a moment to review the following disclaimer. These are the objectives that will be covered during this webinar. Identify the indications of applying oxygen therapy. Select the appropriate form of oxygen therapy for a pediatric patient. Describe the different types of oxygen therapy used. Troubleshoot common concerns with oxygen therapy using clinical cases, and safely manage a pediatric patient on heated high flow therapy. This webinar will provide you with foundational knowledge on oxygen therapy basics in pediatrics, respiratory syncytial virus or RSV, signs of hypoxia, forms of oxygen therapy that are displayed here, and when to seek help. RSV, or respiratory syncytial virus, is most active from about November to April in young infants. Bronchiolitis is a common lung infection of the lower airways. It's most commonly caused by RSV, but can be due to other viruses also. Initial symptoms include fever, runny nose, and cough, but can quickly advance to increased work of breathing, accessory muscle use, wheezing, trouble eating and sleeping, and irritability. It can also lead to pneumonia, especially in children who have underlying conditions that make them more susceptible, such as heart disease, lung disease, diabetes, and a weak immune system. Coronaviruses are a group of common viruses that infect the respiratory tract. The virus that causes COVID-19 is among this group. Both RSV and coronavirus present the same way: fever, runny nose, cough, and then sometimes with COVID you may see more sore throats and some work of breathing earlier on. Children with coronaviruses often only display mild symptoms, while some children may not have symptoms at all, whereas RSV can present more acutely, especially for children with underlying issues. Please have a look at the bronchiolitis webinar if you'd like to know more at connectedcare.sickkids.ca. Here are recommendations we call the Bronchiolitis Bundle that come from a SickKids policy on patients with bronchiolitis. Our recommendations are to use a minimal handling strategy whenever possible, bundle cares, dim lights, and limit stimulation. Assess for fever and treat with antipyretics as indicated. Assess hydration status and consider TFI of 80 to 100% maintenance needs if the child is not significantly hypovolemic. Provide nasal suctioning and repositioning as needed for mild desaturations. If the child's saturations are less than 90% awake and or less than 88% asleep, then apply low-flow nasal cannula oxygen. The recommended maximum flow rates for ages 0 to 90 days is 1 liter per minute. For ages 91 days to 6 months is 1.5 liter per minute, and ages 6 months to 2 years is 2 liter per minute. You also want to attempt oxygen weaning every 12 hours, and then attempt oxygen weaning every 4 hours after the initial successful wean. Assess and document work of breathing every 4 hours or sooner if needed. So why apply oxygen? There are several reasons why we would provide oxygen to our pediatric patients, for example, to decrease work of breathing or shortness of breath secondary to hypoxemia, to prevent hypoxia, to treat pulmonary hypertension, and or other reasons listed here. In the top right-hand corner is a review of basic terms. So FiO2 is the fraction of inspired oxygen in a gas mixture, which is involved in gas exchanged at the alveolar level. We often toggle between FiO2 and oxygen concentration in percentage when describing how much oxygen we're giving a patient. So it is advisable for you to ensure that you are documenting this properly. Room air is FiO2 of 0.21 or 21% oxygen. Pure oxygen is an FiO2 of 1.0 or 100% oxygen. Signs and symptoms of hypoxia include decreased oxygen saturations, tachypnea, change in heart rate, typically reflex bradycardia. Hypoxia triggers a vagal response and slows down the heart rate due to a child's immature nervous system. Dyspnea, cyanosis, a condition associated with severe hypoxia. Central cyanosis is associated with arterial desaturations and involves the skin mucous membranes, lips, tongue, and nail beds. Peripheral cyanosis occurs when there is an increased oxygen uptake in peripheral tissues, so it's not associated with arterial desaturations, and decreased level of consciousness. Measuring oxygen. We know that SpO2 is the percentage of hemoglobin that are carrying oxygen in arterial blood. PaO2 is the partial pressure of oxygen in the arterial blood, and the normal range is about 60 to 100 millimeters of mercury. In pediatrics, we typically do not perform arterial gases as it can be quite painful. Most of our oxygen titration is based on SpO2. So our typical target saturations are greater than 92%. And then for a child who has pulmonary hypertension, we aim for about greater than 94%. In addition, we know that oxygen saturations may not always read accurately, so it's important to decipher the clinical presentation from a faulty reading. A normal signal will show a sharp waveform. In low perfusion states, such as poor circulation and cool skin temperature, the pulsatile signal will display a flattened sine wave. In noise artifacts, such as electrical interference, you will see a pulsatile signal with superimposed noise artifact giving a bit of a jagged appearance. And then with motion artifact, a patient moving, for example, will show a waveform that is quite variable, as you can see in that bottom reading. And then if a child is experiencing poor perfusion, consider switching to a new site or warming up the limb. And rotating sites is often recommended. And then finally, in neonates, the outer aspect of the foot is commonly used, while in peds, the larger toe is typically where the probe is placed. Your hospital policy. It is important to familiarize yourself with your hospital's policy on oxygen therapy. For example, at sick kids, if there is an increasing oxygen demand, the most responsible physician must be notified. The policy states that the MRP will be notified of any significant or sustained relative increase in oxygen requirements. As well, if there is an FiO2 requirement of greater than 0.4, the respiratory therapist will also be consulted. In addition, all patients requiring oxygen therapy must have an oxygen cylinder stocked on the inpatient unit. Ensure the cylinder gauge reads equal to or greater than 1,000 pounds per square inch, or PSI. In this next section, we will review oxygen therapy devices used in pediatrics. Devices differ at every site, and you may not have all these in stock. We're simply sharing options for those who already use them. So, for example, they might already be in your policy, but we'll also provide some alternate recommendations. How to choose your oxygen system. There are many aspects of oxygen therapy that might influence what you choose. Often there might be one key reason from this list why you choose a particular setup. For example, you might have a patient who constantly pulls off their nasal prongs, so you might have to think of a mask instead. You will also have to decide on a high or low flow setup. And in pediatrics, also consider the child's interface requirements, mobility needs, and/or how often they get aerosolized medications. Finally, consider if the child requires short versus long-term humidity, and these options will all be reviewed in the upcoming slides. So let's first think about low versus high flow oxygen needs. With low flow oxygen delivery devices, the oxygen flow delivery from your interface of choice is often less than the patient's inspiratory demand. The example here shows 5 to 10 liters per minute. This results in variable amounts of oxygen provided. So for example, if your patient breathes faster or deeper, then they will pull in more room air around the open interface to make their peak inspiratory flow demand. This will dilute the oxygen, and the oxygen amounts will be variable. Low flow oxygen is often described in liters per minute. So for example, 2 liters per minute via nasal prongs. And then in low flow setups, they typically provide FiO2s in the range of about 0.24 to 0.6 for adults, and then probably more for pediatrics, as their peak inspiratory demand is typically less than that for adults, so they're not pulling in as much room air. In a high flow setup, the flow is high enough to meet or exceed the patient's inspiratory demand, and this results in a consistent amount of oxygen provided from the interface to satisfy the patient's inspiratory demand. High flow oxygen delivery is described in FiO2 and typically delivers FiO2s around 0.24 or to 1.0 or 100% oxygen. This is another way to look at low flow versus high flow oxygen therapy. So low flow oxygen devices are nasal prongs and simple masks. These devices do not guarantee FiO2 because there is room air mixing that occurs in the open systems, diluting the oxygen that's being delivered from the oxygen source via the chosen interface. Whereas high flow device examples are face masks, such as those used with Venturis and large volume nebulizers, as well as heated high flow systems such as Airvo. These devices can guarantee an FiO2 because they meet the patient's inspiratory demand and there is minimal to no room air entrainment. Here are some low flow oxygen devices that we use at SickKids. These will be reviewed in the next few slides. These posters are also available in the community webinar section of the SickKids Connected Care website under resources. Let's look at nasal prongs first. The majority of what we provide now to pediatrics starts with nasal prongs or cannulas as a first-line option. Nasal prongs come in a variety of sizes: neonatal, infant, pediatric, and adult. Oxygen delivery via nasal prongs does not guarantee an exact FiO2 though. The flow rates listed here are for different reasons. First, that our patients entrain different amounts of room air. So for example, using 2 liters per minute on infant prongs would be close to the equivalent of using 6 liters per minute for a teen or an adult, where we would guess their FiO2s or their delivered oxygen in their lungs would be. At SickKids, we do use the 2-4-6 rule for inpatient wards. So maximum flow rates for infants is 2 liters per minute. For pediatrics, it's 4 liters per minute. And for teens/adults, it's 6 liters per minute. And then in the NICU, there is a limit of 1 liter per minute for infants in the neonatal phase. If a child requiring oxygen does not tolerate their nasal prongs or mask, we recommend distraction techniques. There's no easy solution to a non-compliant child. Family caregivers know their child the best, so partner with parent caregivers to find the best technique that works for their child. For infants and babies, some suggestions are physical touch, bundle, a pacifier, maybe a favorite toy, singing, reading, some music, maybe the iPad. For toddlers, the iPad or a phone works well, a video, music, an interactive game, maybe some sensory balls or toys, and physical touch. And also ensure that nasal prongs are secured to the face, and there are some good products such as Tender Grips, as seen here, and Easy Hold tabs are another brand commonly used by our families. These products not only secure the prongs to the face, but also prevent skin irritation when they're having to adjust or change out the prongs. Now let's review the simple mask. A simple mask is one that has oxygen tubing attached and holes at the sides of the mask. And this is what makes it a low flow system, because you can't guarantee an exact FiO2 as there is variable mixing of room air when the child breathes in. It is available in small and large sizes. And the simple mask is typically used for short-term events like post-OR recovery. And the simple mask must be set to about 6 liters per minute or above. And this is based on the most recent PALS guidelines. It can provide an FiO2 in the range of about 0.6 to 0.4. Now let's move on to high flow oxygen devices. The first type of high flow oxygen device on the list is a non-rebreather mask. A non-rebreather mask is one that has a reservoir bag attached. It's used for short-term emergency oxygen and often found in airway boxes and or code carts. Oxygen flow rates should be set so that the reservoir bag attached to the mask remains inflated during inspiration especially. The flow rates are usually between 10 to 15 liters per minute for children to adults, and this avoids rebreathing. Next are the large volume nebulizers and the interfaces that can be used with this setup. Large volume nebulizer setups provide oxygen from 28 to 96%. They work by entraining room air, which mixes with oxygen flow to create the desired FiO2. On the head of the bottle, the desired FiO2 is set, and then the oxygen flow rate indicated beside it is adjusted. The outlet of the water bottle is attached to large bore tubing and then to either a trach mask, face mask, or oxy hood. And if you don't have a large volume nebulizer, a Venturi mask can accomplish the same thing without humidity. And then to note is that high flow cool aerosol used with face masks or oxy hoods or blow-by systems are no longer best practice for reasons of aerosol spread, and that they may not provide humidity levels you're looking for or the FiO2 desired. So if you must transition to this, for example, if your patient's not tolerating nasal prongs, it can be considered, but also think about a heated high flow system as an option, which will be discussed later. Next is the Venturi Mask setup. A Venturi mask is the same idea as nasal prongs, but with a mask. There's usually no humidity provided with this setup, but it can be added if needed through a special connector. There are options to choose a colored connector of the desired FiO2 or a setting on an all-in-one Venturi device, anywhere from 24 to 60% oxygen. The connector or all-in-one device also indicates how much you need to set your flow meter at to achieve that FiO2. And then if your patient is using a large volume nebulizer with oxygen at the bedside and you need to go on transport, they can be switched to a system like this. And heated high flow with a mask is also an option. It delivers more accurate FiO2s with warm humidity, and we'll discuss this in the upcoming slides. Here are some key points with what we've reviewed so far. Nasal prongs should not be set higher than 2 liters per minute for infants, 4 liters for children, and 6 liters for teens. Simple masks and non-rebreathers are for short-term use during emergencies, so it's a quick oxygen setup and should not be set less than 6 liters per minute to avoid rebreathing. And if you're using a Venturi system, use the connector as a guide to determine what flow rate to set for the desired FiO2. And large volume nebulizers are used to provide more specific oxygen percentages, and they do provide some humidity. And this setup is usually used with a mask interface in Paediatrics. And then it's always important to remember that you should know your patient's baseline status for oxygen therapy and work of breathing. So just a little note about humidity. Generally, bubblers provide minimal humidity to the patient, and we know that cool humidity is not an evidence-based practice according to bronchiolitis and croup guidelines. In addition to blow-by therapy via large volume nebulizer, it is also not recommended therapy. The exception is that when a large volume nebulizer is used with a tracheostomy mask, when heated high flow cannot be used. And any aerosolized humidity is considered an aerosol generating medical procedure or an AGMP. Always double check your device and bedside setup at minimum start of shift. Examples of safety errors and risks can include accidental connection to air instead of oxygen. Some sites may not even have airflow meters. Having a low flow flow meter attached when it's not indicated, accidental bumps to settings, accidental loose connections or disconnections, and unavailable connections to the manual resuscitation bagging system. To summarize low and high flow systems, this is a helpful slide showing our simplified oxygen pathway. And to highlight again, please note the nasal prong limits in Paediatrics. Also note that we would still use a high flow mask if that is more comfortable for the child. And again, the simple mask and non-rebreathers are generally used for short term. When escalating therapy, contact respiratory therapy, consider a heated high flow nasal cannula system, and also consider a consult to the rapid response team or the equivalent at your facility. We will now move on to heated high flow in Paediatrics. Here is a quick review of normal airway physiology. So we know that the major lung functions include ventilation, oxygenation, and airway defense, and preservation of these functions by the lung is dependent on the mucociliary transport system to maintain clear airways through secretion clearance and remove pathogens via secretion clearance. Heated high flow therapy terminology. The goal of heated high flow is to deliver humidified gas to the lung, which is optimal for cilia function. Airvo is a device that provides high flow humidified gas that is warmed, and in pediatrics this flow is typically in the range of about 30 to 50 liters per minute, which usually meets the child's spontaneous inspiratory demand. High flow nasal cannulas are the recommended interface as they are directly provided into the nares and they meet the patient's inspiratory demand and help to reduce work of breathing. Patients with respiratory disease often develop CO2 retention as a result of their increased work of breathing and respiratory pump failure. This is due in part to their inability to expel enough CO2 from their upper airways during expiration. The high flow rates of heated high flow therapy combined with the cannula interface results in washout of the anatomical dead space from the upper airway, replacing some of the CO2 that would otherwise be rebreathed with fresh respiratory gases. As a result, heated high flow therapy increases alveolar ventilation and reduces CO2 retention. Heated high flow is warm humidified oxygen therapy. This is high flow provided via a mask. Although the mask provides warm humidified oxygen, it does not necessarily affect work of breathing as it is an open system. So when we talk about heated high flow, this is the terminology that we go by. Heated high flow is indicated for patients with mild work of breathing and hypoxia, thick tenacious secretions that are difficult to clear, trach patients for humidification purposes, and is contraindicated in acute decrease in level of consciousness, severe respiratory distress, any impending respiratory failure, and if the child needs non-invasive or invasive ventilation instead. Airvo can be provided up to 2 liters per minute per kilo with up to 60% oxygen on a wards unit. Here is the Airvo setup. As you can see here, there is the base unit. Along the side of the base unit is where the oxygen tubing is attached, and that would go to your oxygen source. In the front of the unit, you have the water canister, which has a line that goes to a water bag, a disposable or reusable type of water bag. On the top of the unit is where the patient tubing is attached, and that goes to your patient interface. In this illustration, a high flow nasal cannula interface is illustrated. What interfaces can be used with Airvo? So you may follow manufacturer recommendations for which interface to use based on size. The interface is the device used to deliver the flow to the patient. Fisher and Paykel pediatric nasal cannulas that are used with Airvo are called Optiflow Junior nasal cannulas. Fisher and Paykel provides sizing charts based on weight and maximum flow rates as well. This handy chart outlines patient weight and the corresponding Optiflow Junior nasal cannula to use and the recommended flow rate ranges. Note also recommendations for the different sizes of wiggle pads, which are the stickers that help adhere the prongs to the face. For the Optiflow Junior cannulas, you first have to ensure the sizing is correct. There must be space around the cannula. The manufacturer recommends that the cannula should take up no more than 50% of the size of the nair. That is not always easy to appreciate visually, but the important point is that there is a gap around the cannula for the child to breathe around. If you need to use a higher flow rate, but the chart recommends that you go to the next size up cannula, then be cautious that you still have room around the cannula. And a few other points to be aware of. The adult prongs don't have the wiggle pad stickers as you see in peds, and the wiggle pads are highly recommended for especially for sensitive skin and allow for again that easy application and cannula adjustment. And to prevent any strangulation risk in pediatrics, ensure you're securing the prong tubing at the back of the head, avoiding the front of the face below the chin. So what should your orders include? First of all, the name of the therapy, so heated high flow humidity therapy, Airvo. The interface, so whether you're using a nasal cannula, face mask, or trach mask or adapter. The temperature setting, either 31, 34, or 37 degrees are the options on this device. The flow setting in liter per minute and based on your hospital policy. So we typically start at 2 per kilo for those less than 10 to 12 kilos. The handy chart on the right corner here is based on the Paris 2 protocol, which is a multi-center randomized trial to investigate early high-flow nasal cannula therapy in pediatric acute hypoxemic respiratory failure. Sometimes for flow there might not be an order, and sometimes with medical directives in place, RTs for example may have the flexibility to choose a starting point. Oxygen prescription, 0.21 or 2 target saturations. Here's how to access the junior pediatric mode if you're using the Optiflow junior nasal cannulas. Press and hold the mode button for 5 seconds and the junior mode will be activated. You'll see the butterfly and the bird. The new target settings will appear on the screen. The Airvo unit will now set the temperature limit to 34 degrees and the flow rate limit to 25 liters per minute. And then if you want to deactivate this, you press and hold the mode button again for 5 seconds. Please note that the junior mode is maxed out at 25 liters per minute. So if you're using the extra large gray colored Optiflow junior nasal cannulas, they go from 10 to 50 liters per minute, so they fall in both ranges. So if you need to go greater than 25, then you'll have to switch to the adult mode by deactivating the pediatric mode. The latest version of Airvo is called Airvo 3 and is being trialed in Canada at certain hospitals such as Sick Kids. Additional features from the current Airvo 2 unit include internal battery of up to 30 to 40 minutes, high and low pressure oxygen inputs, a large touchscreen menu, extended flow ranges. It's compatible with Optiflow interface sizes for pediatrics. And data trending as well. Please note that this unit is not available in home care at this time, so it's just being trialed in the hospitals. When setting up the device, there are a few checks that should be in place. So when checking the device, ensure that there is proper level of water in the chamber. The sterile water bag attached is changed as needed. It does not need to be changed every 24 hours. The circuit or the tubing and interface are clean. Ensure that there are no cracks or leaks in the circuit or the interface, that the circuit is not wrapped in bed sheets or blankets, and that it's not placed against any skin or other wires. You also want to verify the settings against the prescription. So you hit the mode button or what looks like the play button to see the settings. You want to check the flow rate, temperature, and the FiO2. If oxygen needs adjusting, this is done by the flow meter on the wall, and you check the resulting FiO2 being analyzed on the device. And then you want to perform a respiratory assessment before, during, and after application of therapy. So you want to check the vitals, heart rate, respiratory rate, SATs, chest assessment, any need for suctioning or pulmonary clearance. The medical team is to adjust the settings, and if your settings are different than what's been prescribed, you want to clarify that with the MRP. And then, of course, remember that prior to applying the interface, you want to make sure that the nares are patent and suction if needed. That the prongs are in good condition, they're not kinked or stretched or broken or torn. Ensure the prongs are the proper size, so not more than 50% of the diameter of the nair. And verify that there is a gap at the septum to avoid any irritation. And if the child is improving, you'll see a decrease in respiratory rate. You should see stabilization of the SATs and FiO2 requirements, improvement in the work of breathing and the child's comfort, and heart rate, if elevated, should improve, assuming a normal fluid status. Monitoring the patient. So first of all, understand when the therapy is indicated for the child. Perform vitals before, during, and after use. Perform continuous oximeter monitoring, so your SATs and heart rate along with respiratory rate and work of breathing. Perform nasal and oral care every 4 hours or as needed or as per your agency's guidelines. If the patient requires suctioning, suction one nair at a time. So you remove one side of the prongs from the wiggle pad, suction, place the prong back, and then repeat on the other side. You want to assess the patient on heated high flow every hour and as needed or as per your hospital's policy. In the hospital, initial assessment should be done at the start of shift in collaboration with RT and RN. And this is to assess the patient and the plan of care for the shift. And then it should also include what to do in the event of an escalation of care or even the weaning of a child from heated high flow, and then a review of the heated high flow setup if needed. Assess for skin breakdown, adjust the prongs and tubing regularly, reapply new wiggle pads as needed. And then when delivering inhaled medication, the nasal prongs must be removed. Normal saline nebulizers are not recommended as high flow is already humidified. And finally, feeding by mouth or tube should be commenced if the patient is tolerating heated high flow. This is also to be assessed per patient and adjusted as needed. Airvo devices have some common built-in alarms. The first alarm is the check tube alarm. In this case, check that the heated breathing tube is plugged in properly and not damaged. Check for leaks alarm. Check that the water chamber is pushed in, that the tubing is connected properly, and that the interface is fitted properly. And also ensure that the filter at the back of the unit is attached. Check for blockages alarm. Check that the interface and tubing are free of any blockages. And finally, check water alarm means that the chamber has run out of water and needs to be refilled. What is now going to be presented are SickKids heated high flow nasal cannula pathways that we use throughout our organization. We would start our policy in terms of flow rates and what we would do with our high flow nasal cannula interface. So this is specific to high flow nasal cannula. We typically start those less than 10 kilos on a 2 per kilo flow rate for support, and those greater than 10 kilos, we typically adopt a range of sizes. So 10 to 30 kilos, we say 20 to 40 liters per minute, and those 30 to 50 kilograms, we say start at 40 to 50 liters per minute flow rate. And then those greater than 50 kilos, you can use your adult guidance you have at your sites. One thing to remember is that the 2 liter per minute approach is really for those infants, and that stems from some of the research in bronchiolitis and the use of high flow nasal cannulas on the wards. It is safe to use 2 per kilo, and we've actually moved away from titrating flow rates in this population altogether and approaching it as a 2 per kilo strategy. So once we initiate the therapy, we then establish what FiO2 needs they have. Once we've established oxygen needs based on targeted ranges, we then look at the patient's response within the hour. So anyone on high flow nasal cannula, if they tolerate it and respond well, you should see that the response relatively quickly, and this is our way of evaluating how they're tolerating the high flow nasal cannula. So we would look at heart rate, respiratory rate, work of breathing, and specific in the bronchiolitis population, you can use the bronchiolitis severity scoring tool as well. For our inpatient wards, we have a threshold of less than 60% oxygen or 0.6 FiO2, and we have used this in our guidelines because we have also what is known as a critical care response team, like a rapid response team, who typically get involved with our patients who are requiring more than 60% oxygen. So it's not a hard 60% where we change to NIV or anything, but we do involve the team for consideration of escalation, and likewise across the whole population of pediatrics. If anyone is presenting with severe work of breathing, we can initiate high flow nasal cannula for them, and we could involve rapid response or whatever medical leads you have at your sites in the guidance on how to manage these patients, and when it's appropriate to be reaching out through critical or whatnot to other resources you have in the community. If they tolerate the initiation and you have improvement in these vitals, then we would say they're a good responder to it, and we would keep them on heated high flow nasal cannula and titrate their FiO2 to the target range. So we've covered some of this already, but these are the weaning guidelines, and we have two approaches to weaning. One is specific to bronchiolitis, which has stemmed from some of the research on how to approach that population. So for bronchiolitis patients, we typically don't even adjust their flow rates at all. We actually wean their FiO2 close to room air or down to room air, and then we take them off high flow nasal cannula. Sometimes there is enough mild to moderate distress, and you may decide to continue therapy for a little bit and then reassess a little time later. Typically, even if there is a bit of distress, but if you can hold, but if the child can hold their SATs on room air for this population, we would try to take them off high flow nasal cannula. For the general pediatric population, they would have their ongoing high flow nasal cannula therapeutic flow rate. So we might drop their flow rates in this as a 1-stage or 2-stage approach. So if they're on 2 per kilo, we might drop them to 1.5 or directly to 1 per kilo on the high flow nasal cannula. And then if they tolerate that, then we might take them off. The other work done recently is looking at overuse of high flow nasal cannula, specifically in the bronchiolitis population. So we know that this population has some work of breathing. They may have some oxygen need, but not all of them require high flow nasal cannula to support them through the course of their illness. We've implemented a bronchiolitis severity scoring tool. The bronchiolitis webinar goes into this in more detail, so please have a look at that. So it's making sure you're not assessing, for example, tachypnea when the patient is incredibly febrile, and that you've made sure that their nasal passages are suctioned. For this population specifically, you want to make sure that they have low flow nasal cannula guidance in terms of what would be reasonable low flow nasal cannula oxygen support that we would tolerate. So this pretty much tells you that they're not going to fall into that severe category and require escalation based on current needs. So after doing this scoring, if they tolerate low flow nasal cannula with mild work of breathing with a mild to moderate score, you don't actually start high flow nasal cannula in this group of patients. But if you do notice that after a period of stabilization and bundling and making sure all your cares are done well and they still have worsening bronchiolitis severity score or need more oxygen, then those flow rates we would be that we would tolerate, the RT would be paged to initiate high flow nasal cannula in this population. So it's a bit more of a pathway for trying to differentiate those that need just a little bit of oxygen and might be better without needing high flow nasal cannula support versus those who might benefit from it. We will now work through a case study. Xavier is an 18-month-old boy admitted to the hospital with bronchiolitis. You receive him on day 1 at the beginning of your shift on half a liter nasal prongs. You're told on report that he has developed increased secretions overnight, but is demonstrating a strong cough to clear them. You go in to complete the morning assessment while Xavier is sleeping, and you notice the following vitals. His heart rate is at 135, respiratory rate 42 breaths per minute, SATs are at 87 to 90%, and his blood pressure is 85/45. He is asleep and demonstrating mild intercostal indrawing. His P1 bronchiolitis scores are unchanged from 5 to 6, and his oxygen saturation goal is greater than 88% while asleep. So what would you do next? You can increase nasal prongs to keep the SATs greater than the goal or the order, increase and assess up to a maximum of 2 liters per minute, and then consider all the aspects of the bundle, for example, suctioning and repositioning. Xavier is now on day 2 of his admission. You increase the oxygen flow rate on his nasal prongs to 2 liters per minute. You wake the patient up and suction him via the nasopharynx with a suction catheter, eliciting a cough. His SATs when awake is 89 to 92%. His work of breathing is worsening, and so are his bronchiolitis scores and bedside pews. His vitals are heart rate of 120 beats per minute, respiratory rate 62 breaths per minute, SATs are between 89 and 92%, and his blood pressure is up at 110 to 64. So what would be your next step? So for those of you who thought he did high flow, this would be a good next step. This will allow you to provide an accurate FiO2 and you titrate his oxygen levels up to what he needs. You also want to notify the IPP team of his increasing oxygen requirements. So your team decides to initiate high-flow nasal cannulas. Xavier weighs 11 kilograms. So what would be your starting settings? So you want to start at 2 per kilo. The high-flow nasal cannula can be set at 34 degrees for temperature in the pediatric mode. The flow is set at 22 liters per minute because he weighs 11 kilos. And the FiO2 is set to keep sats greater than 90%. So the left column changes to the right column after initiation. So you see here that that is a good response. So your next step would be to continue to support him on high flow nasal cannula and continue titrating the FiO2 to sats. So this is how we would approach going from standard oxygen to high flow nasal cannula using some objective measurements and how we would approach that. Thank you for viewing this webinar. Please see other webinars and resources at connectedcare.sitkids.ca. Please contact us with any questions at connectedcare.inquiries@sitkids.ca. Thank you.